morning, everyone. Have a great Sunday. I am Prashant Agrawal on the behalf of Adler Oncology. I would like to welcome Dr. Shweta Pathak and Dr. Regis Dilato as speakers. I would like to welcome our chief guest, Dr. Disha Kriplani, and the moderator, Dr. Amit Khurana, sir, as always. So I welcome all of you and welcome all the discussants. With your permission, sir, should I give the presentation about the Adley Oncology?
Sure, please go ahead.
So Adley Oncology having a mission of advanced healthcare with the innovation, quality, and the collaboration. It is one of the fastest growing pharma company in India. And as I told you that it works on the innovation, we have recently launched the Edexit OS, that is methotrexate oral solution, addressing the unmet need in the pediatric patients. It is bioequivalent in fed and the fast conditions both. Not only this, the company is having the rich portfolio in the hemato-oncology segments with the products like MDS Plus, MDSO, Bidan, Kylonib, Carfimib, Atpomide, Pegalisgen, and many more. In hemato-oncology, patient first is our guiding principle where we want to force upon the patient compliance, patient support, patient education, and cost effectiveness. Not only in the domestic market, but the company is expanding its wing in the international market as well. It has been approved by EAEU, Zezibona, Coffee Press, and many other international accreditations we have in our pocket. The company is helping the needy patients through the patient assistance program, which is very effective and endorsed by the many doctors that we are one of the fastest providing the patient assistance program by easy to process drug support within 24 hours to the patients. Company has been awarded by the Forbes for consecutive 4 years and has been recognized as a best manufacturer in India in oncology. With this, I would like to say thank you and I hand over the session to Dr. Amit Khurana.
Thank you, Prashant. Well, very good morning to all of you and good afternoon and good evening to all others who are joining from this part of the world. Today we have got two guest speakers. The first one is Dr. Shweta Pathak from Jabalpur and the second guest speaker is Dr. Regis Pifolti-Letor from Paris, France. Our first guest speaker, Dr. Shweta Pathak from Jabalpur, is going to lecture us on unusual presentations of pediatric leukemia, lessons from real cases. And our second guest speaker, Dr. Regis Pifolti-Letor from Paris, France, is going to lecture us on paroxysmal nocturnal hemoglobinuria. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Adley Oncology, and very well managed by Perfect Square. I thank Mr. Ashutosh Shukla and team from Adley, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Disha Kriplani from Mumbai, our guest speakers for the day, Dr. Shweta Pathak from Jabalpur and Dr. Regis Pifolti-Letor from Paris. All our discussants were themselves very eminent hematologists as well as pediatric hematologists, and you participants for sparing your Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 28th of February 2026 from 7 p.m. Indian Standard Time and 7:30 a.m. Central Time, we have Dr. Sajid Kumar from Mayo Clinic, Rochester, USA speaking to us on Can we cure advanced stage classical Hodgkin's lymphoma in 3 months? And the following day, that is Sunday, 1st of March 2026 from 11:30 a.m. Indian Standard Time, we have Dr. Roop Jyoti Sharma from Guwahati, Assam speaking to us on CLL, recent advances in management. Let me introduce our discussions for the day, and they are well distributed here in alphabetical order. I will pause for a while for you to look on all our discussions for the day for very eminent hematologists, hemato-oncologists, medical oncologists, as well as pediatric hematologists all across the country. So some more over here. So these are our discussions for the day. And now it's time to introduce our first guest speaker for the day. We have with us Dr. Shweta Pathak from Jabalpur. Dr. Shweta Pathak is pediatric hemato-oncologist and BMT physician, associate professor, Department of Pediatrics at Netaji Subhash Chandra Bose Medical College, Jabalpur, Madhya Pradesh, India. She is a pediatric hematologist and oncologist and bone marrow transplant physician with over a decade of clinical, academic, and research experience. She is currently working as an associate professor at the Department of Pediatrics at NSCB Medical College, Jabalpur. She plays a pivotal role in advancing pediatric cancer and transplant care in central India. Establishing the Pediatric Hemato-Oncology Unit at the State Cancer Institute, Jabalpur, where more than 350 children with cancer have been treated with encouraging outcomes. She also established the first government pediatric transplant unit in Mahakoshal region of Madhya Pradesh, marking a major milestone in equitable access to curative therapies. She has got clinical expertise which spans the pediatric leukemias, hemoglobinopathies, aplastic anemia, and complex transplants in limited settings. She is also an active researcher and have authored and co-authored over 20 peer-reviewed publications and serves as a reviewer for leading pediatric journals. She also presented extensively at national and international forums, including ISBMT, APBMT, SIOP, and FOCON. She has worked and has been recognized with multiple awards, including honors from ISBMT and APBMT. She has got academic interests, including pediatric leukemias, transplant ethics, and strengthening pediatric oncology services in government institutions. Today, she is with us and she is going to lecture us on unusual presentation of pediatric leukemia lessons from real cases. Our second guest speaker, Dr. Regis Pifolti-Leto from Paris, France. Let me introduce him again to all of you. And he has already presented before also multiple times on this platform. Dr. Regis Latour is head of the Hematology and Bone Marrow Transplant Department at Hospital Saint Louis, Paris, France. He received his MD degree from the University Paris at Lariboisière in 2003 and his PhD degree in immunology from the Pasteur Institute in 2006, where he worked on regulating T cells in graft versus host disease after hematopoietic stem cell transplantation. He was trained in hematology at Paris hospitals and did his postdoctoral fellowship at the Hematology Branch, National Institutes of Health, USA from 2008 to 2010 on aplastic anemia and paroxysmal nocturnal hemoglobinuria. He obtained his tenured professorship position in 2014. He is responsible for the French Reference Center on Aplastic Anemia and PNH, as well as of the French Organization for Rare Hematological and Immunological Disorders since 2016. He is currently the head of the Hematology and Bone Marrow Transplant Department at Hospital Saint Louis, Paris, France since 2022. His research interest focuses on bone marrow transplantation, bone marrow failure, and paroxysmal nocturnal hemoglobinuria. He is also the principal investigator of many research studies on bone marrow failure at the national as well as international level. He is the author as well as co-author of more than 350 papers quoted in PubMed and is a regular reviewer for journals like New England Journal of Medicine, Blood, Hematologica, British Journal of Hematology, Biology of Blood, and marrow transplantation, as well as bone marrow transplantation. And he's also going to present the second lecture that will be on paroxysmal nocturnal hemoglobinuria. But before our speakers does that, we have a special guest and chief guest for the day. We have with us Dr. Dipsha Kriplani, the clinical hematologist from Breach Candy Hospital, Mumbai. Let me introduce Dr. Dipsha Kriplani to all of you. Dr. Dipsha Kriplani is a dedicated clinical hematologist with a strong commitment to patient-centered care. She is currently associated with Breach Candy Hospital, which is one of the India's leading tertiary care institutions. Her clinical interests span benign as well as malignant hematological disorders. She is known for her methodical, evidence-based approach to diagnosis and treatment. With a keen interest in teaching, she actively contributes to the academic growth of students as well as trainees. She believes in simplifying complex hematology concepts for effective learning. Her practice reflects a balance of clinical excellence and compassionate care. She values multidisciplinary collaboration to achieve optimal patient outcomes. She keeps herself updated with evolving advances in hematology and oncology. She is also respected for her professionalism, clarity of thought, and dedication to lifelong learning. It's my privilege to welcome Dr. Dipsha Kriplani to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Dipsha Kriplani.
Thank you, sir. Thank you for giving me this opportunity to speak to this young bunch of hematologists with us today. I would like to speak to all of you as I also have trainees under me. Uh, Good morning and good afternoon from wherever all of you young hematologists are joining. And at the offset, I would like to congratulate all of you. I believe all of you are training hematologists. So, congratulations, you have survived medical school and now you've survived the trauma of your first abnormal CBC and you've come such a long way to actually becoming hematologists. Now, people often ask, why hematology? And I say, I find hematology like solving a mystery. You're given clues in the form of abnormal CBCs, peripheral blood findings, abnormal labs, and suddenly you find yourself to be Sherlock Holmes with a microscope and a stethoscope. And don't you just love a mystery? You ask for the next level of clues, you ask for bone marrows, you ask for flow cytometries, and then you have to put all of these clues together. And these abnormal findings, you whether you have a spleen, whether you have lymph nodes, or what's the PET scan, you put all the clues that you've been given, and you try and find the actual treasure, which is the diagnosis. And it is real fun, believe me. So hematology is where medicine meets detective work, and that makes it fun. Yes, the field is demanding and it is also rewarding. You might find your nights arguing with platelet counts or trying to chase hemoglobin levels. You become best friends with LDH. But here's the truth, hematology makes you deal with one of the worst chemotherapy protocols in leukemias, but it also gives you the rare chance of aiming at cure with lymphomas, which in malignancies is not something you can say very often. So, hematology has reached a very interesting time and phase, and you're all lucky to be a part of this field at this point, where chronic leukemias they've become so normalized, like this just another comorbidity where you just take a medicine and you're managing your life, living it normally. Bone marrow transplants have become another routine procedure. They're not feared anymore. And we are at the brinks of having such innovative therapies coming in, CAR T therapies, bispecific antibodies, that we are and aiming to incorporate them in our daily practice and making relapsed refractory cases as normal, as achievable as possible. So I wish all of you young hematologists best of luck. Do enjoy your session today. It's great fun. I mean, great lectures coming up. But remember to add a sense of humor and take it with a pinch of salt. Everything that comes along your way today. Good luck, all the best students. Please enjoy your sessions today.
Thank you, Dr. Dipsha Kriplani. Wonderful words of wisdom. And thank you for accepting our invitation as our chief guest for the day today.
Always a pleasure, sir.
Your words means a lot to us. Thank you so
Thank
much.
you, sir.
And now I request our first speaker, Dr. Shweta Pathak, to please present her presentation.
Good morning, sir.
Yeah.
First of all, before starting, I would like to say thanks in regards to Amit sir and respected Dr. M.B. Agrawal sir. Since the beginning of our hematology, we have been hearing about sir's achievements and we are really very fond of him. So thank you very much for this present opportunity, sir. And sir, your the way you introduce the speaker is always very encouraging, sir. Thank you very much for your encouraging words. Thank you, sir. So shall I share my screen?
Yes, please do.
Okay. Is it visible, sir?
Perfect. Full screen mode, please.
Yeah. Now it is.
Perfect.
Is it okay? Yeah. Shall I start?
Yes.
So with due permission from Dr. Amit Kumar Khurana, sir, I would like to present some unusual cases of pediatric leukemia, which we really come across in our clinical practice. So I'm basically pediatric hemato-oncologist. So my presentation is mostly focused on pediatric cases and pediatric literature. So if anyone has any question regarding adult cases, we have expert over here. So straight away to the cases. Before we start, I just want to give a brief introduction on ALL. ALL, as you all know, it is a commonest malignancy, accounting for 30 to 40% of all cases. in which ALL comprises of 70 to 80% cases, whereas AML accounts for almost 20% cases. We do see some mixed phenotypic leukemias and other unclassified leukemias as well, but which is very, very rare in pediatric patients. So as you all know, majority presents with classical symptoms, which is fever for few weeks, then bleeding manifestations, then hepatosplenomegaly and lymphadenopathy. But not all. Some may present with some unusual presentation, and this unusual presentation may leads to increased induction mortality due to delayed diagnosis, organ damage, and ICU admission. Because risk in pediatric risk stratification depends on the WBC, initial WBC count. So as the time passes, the WBC goes on increasing from pancytopenia to frank blast present in the peripheral smear, and from standard risk, the child will go into the high risk leukemia. Then, so how commonly we see these non-classical cases? So up to 20 to 30% children, they have non-classical onset, in which bone pain used to be a very common unusual presentation, which we see approximately 15% in our own cohort. Then there is something called aleukemic leukemia, where your bone marrow is flooded with the blast, whereas periphery you don't see the abnormal atypical cells or blasts, which is 5 to 10% of the cases. CNS dominant disease that can also go unrecognized, because we have seen many patients presenting with facial palsy and some neurological manifestations like stroke, focal neurological deficit. They come to neurology department or ICU, and then when they see CBCs, that time they seek our opinion. So straightforward coming to the case, here we have a 14-year-old male child presented to us with the history of fever for 20 days, left-sided hemiparesis 3 days before admission. Physical examination showed pallor and hepatomegaly. Liver was 4 centimeters below the right costal margin. There was no history of bleeding, rash, double vision, lymphadenopathy, or splenomegaly. On lab, we found that HB was 6.2, total count was 2,400, and differential was neutrophil 54, lymphocyte 45, platelet 30,000. So on Rossley looking, overall it looks like pancytopenia. So the child was admitted in intensive care unit under pediatric neurologist. But looking at these pictures, they ask our opinion. CT head was already done in intensive care unit, which showed right temporoparietal occipital region infarct. And on peripheral smear, there they showed there was no abnormal cells. There was only marked leukopenia and thrombocytopenia. So since the child had pancytopenia, so our plan was we went ahead with leukemia. So APML is anyway rare in pediatric patient. We usually see patient presenting with bleed. This was very unusual child who presented with infarct even with a low platelet counts. So this was very unusual, and for the first time I've seen this kind of case. Since we got the bone marrow report, PML-RR was positive. Initially, FISH was done, quantification was not done, and marrow was already done. So we could not repeat the sample for PCR. So on that basis, we started the child on ATRA and ATO for initial 28 days. The child also had differentiation syndrome on day 7, which was well managed with injection dexamethasone and other supportive care. For almost like 20-25 days, the child was in ICU only. When his count started improving, we shifted the child to our oncology ward and we did the marrow. On 28 days after induction with ATRA and ATO, the child, the PML-RARA was still positive, 14.68%. Hence, we continued induction with ATRA and ATO for another 2 to 3 weeks. So then on day 56, when the repeat PML-RARA quantification was done, it was 0. So it was an excellent response following 56 days of ATRA ATO, which we usually give in these kind of cases. Now, afterwards, the child remained well. There was no admission required. Child he has recently completed his consolidation cycle 1, and now he's planned for second cycle of consolidation. So we got an excellent response. So discussion-wise in APML, morbidity and mortality results from the complication associated with bleeding and infection, which usually dominates the picture. Thrombotic events like cerebral infarction, as we have seen in this case, and acute MI, it is very, very rare, and even more rarer in pediatric patient. So in the present case, the child had presented with cerebral infarct before the initiation of therapy, which again makes it a very rare presentation. So we went through some of the literature. So in this case report, they have reported 2 cases. which presented, first was 13-year-old boy who was presented with headache and papilledema. His MRI showed sinovenous thrombosis. Peripheral smear revealed blast. Diagnosed as translocation 1517 positive ALL. He achieved remission. However, he died after 4 years with relapse. Then there was again second child who also has a very poor prognosis. The 8-year-old boy again presented with right hemiparesis like our case. MRI showed left MCA infarct, and then there was blast in the peripheral smear. And then 2 weeks, he again died due to thrombosis and bleeding, secondary bleeding. So these are the two cases. I have seen some of the interesting cases in adult. There were many, but I have just seen taken this because this was 35-year young adult who presented with again cytopenias, hemoptysis, more than 80% promyelocyte confirming APML. He has dual thrombotic complication, pulmonary thromboembolism as well as cerebral venous thrombosis, APML. Again treated like we have treated our child with atra-80 on anticoagulation, achieved good hematological response, which highlights the effectiveness of combination therapy. Fortunately, this patient also did well and now in complete remission. So we also went through some of the literature, which in which thrombosis is a presentation in acute promyelocytic leukemia. So this was the population this was a review study in which they have studied many patients. Median age was 40 to 50 years. Pediatric APML included only in one series, in which they have included children and adolescents less than 18 years. Others are all adult studies. Overall thrombosis incidence in these studies were 5 to 20%. Arterial thrombosis 2.3 to 6.3%. Most common events were cerebral ischemia and acute myocardial infarction. Timing of thrombotic event, which they have seen in their studies, was most frequent at initial presentation, during induction chemotherapy, and it was also reported during consolidation. So it is not like they only present at the time of presentation consolidation. So treatment of APML is not at all easy. Induction is also not easy. Once you start chemotherapy, you tend to see many peripheral blasts coming in the circulation, and then it takes long time for them to come into the remission. So during that phase, they develop differentiation syndrome, sudden onset distress. They require ICU admission, multiple blood product support, repeated fibrinogen D-dimer monitoring, and it is again a very, very difficult task to bring these children into remission. So these were the study which were included in this review. Again, as I've said, the incidence vary from 5 to 20%. And the key event noted, the thrombosis episode noted during the induction or consolidation or at presentation. This is the only study in which they have included pediatric and adolescent patient also, in which the bleeding incidence is little higher, 80%. So the key message from this cases, majority of thrombosis data in post-ATRA era derived from the adult population is very, very less. It is just 3 to 10% in reported series. Both arterial and venous thrombosis can occur. Thrombosis can be an initial presentation of pediatric AML and can cause significant mortality and morbidity, as we have seen in that case report series. Then coming to the second case, this is also a very interesting case, very unusual case for us also to deal with. This was again a 15-year-old male child presented with fever on and off, 15 days, vomiting. He also presented to us with decreased urine output, hematuria, renal failure, and there was classical skin lesion, which I have also not seen in any of my previous cases. And there were 2-3 such lesions, one over the ankle and the other in the knee joint. So we have done the basic investigation. CBC showed hemoglobin of 8.9, total leukocyte count 5,600. There is relative lymphocytosis. Peripheral smear was not done. So with this relative lymphocytosis in a big cell, so they ask our opinion. X-ray was within normal limit. X-ray skull and skeletal survey, it also showed multiple osteolytic lesion. USG showed hepatomegaly and raised kidney echotension. So interestingly, on day 3, within 2 days of admission, his peripheral smear, the peripheral total leukocyte count gone up to 26,000 with the blast of, he also showed 190, creatinine was 3.1, calcium level was 14, child was very, very sick. Child was in ICU. We did parathyroid workup, so everything was negative. Parathyroid related workup was also negative. So since this peripherals were already showed blast, we were little delayed in diagnosing this child by 48 to 72 hours. We again went ahead with the leukemia. 1 dose of resveratrol was given since uric acid was also high, plus diuretic after hydration therapy. So, and we during that time we have seen some literature which suggested the role of xalendronic acid to treat the hypercalcemia part. So we have given single dose of xalendronic acid, 0.05 mg per kg IV over 60 minutes. This was the first time when I had used this xalendronic acid for this clinical indication. But we have got excellent response just after this hydration, allopurinol, then xalendronic acid, 1 dose of resveratrol. The metabolic picture completely resolved. So post induction, and then we went ahead and started the chemotherapy. Post induction MRD was negative. Fortunately, that this child has completed maintenance chemotherapy and now coming to us on regular follow-up. So this was the excellent result which we have got despite having a very critical initial presentation. Hypercalcemia is potentially a life-threatening event and is associated usually with nausea, vomiting, anorexia, weight loss. As we have seen in our case, this is usually seen in adult and very, very rare in pediatric, with incidence varying from 0.4 to 1.3%. So we do see hypercalcemia, but we have usually seen this with solid malignancy, like rhabdo, Hodgkin's, non-Hodgkin's, some metastatic tumors. So in those cases, we do have seen hypercalcemia, but this was the first case of ALN in which I have seen this kind of malignant hypercalcemia, which was really very difficult for us to treat. Fortunately, we got a good outcome. Then some case reports which I have seen to clinical presentation. Here also, the calcium level was very, very high. Calcium was 19. This child was also presented with AKI, with similar anemia, thrombocytopenia. On flow, there was this was precursor B cell ALL with CNS positive, classified as intermediate risk. And they have also treated this child with hypercalcemia, hydration, and Lasix. Renal function normalized, and there was good response to chemotherapy, and this child has also achieved complete remission. This is another child, very small, 3-year-old, presented with fatigue, fever, limping, and again had altered sensorial. Calcium was also high. Was done, which showed B cell ALL with malignant hypercalcemia. They were also treated the child in a similar way: hydration, loop diuretic, bisphosphonate, which is pamindronate, with extensive cardiac. One more 4-year-old child, a 4-year, 8-month-old child, presented with prolonged fever, vomiting, bone pain, with almost normal platelet count, 7,400 WBC count, 8.6 hemoglobin, no blast on peripheral smear, multiple lytic lesion and bilateral calculi suggested B cell ALL.
Dr. Shweta?
This child also achieved complete remission following induction. Yes, sir?
Your voice is breaking in between. If you can just switch off your video.
Okay.
Yeah, that would be better. Yeah, because if you can just switch off your video.
Yeah, 1 minute, sir.
Yeah.
Is it okay, sir, now?
Perfect, perfect. Please go ahead.
Okay. So, key message from these cases: severe parathyroid hormone independent hypercalcemia may be a rarer initial manifestation of pediatric acute leukemia and without peripheral blast, which was seen in our case. Hypercalcemic crisis is an oncological emergency which requires prompt recognition and aggressive stabilization. IV bisphosphonate are safe and highly effective for rapid calcium control in children. Early metabolic correction enables timely diagnosis, and initiation of leukemia-specific therapy will improve the outcome. So, am I clear now, sir?
Better than
Amit
before.
sir, am I clear?
Yeah, better than before.
Okay.
Yeah.
Okay, sir. Okay. This is the third case, a 14-month, very small, interesting case. 14-month-old female child presented with high-grade fever for 10 days, progressive pallor and irritability. There was no history of Down species. The parents did not aware of this Down species. We only has explained them. When pallor was present, the child was irritable, the child was febrile, and hepatosplenomegaly was present. No significant lymphadenopathy noted. CBC showed hemoglobin of 7.6, total count 14,930, and a platelet count of 19,000. Peripheral smear also showed microcytic hypochromic anemia. Outside, this child was treated with nutritional anemia and sepsis. This child was admitted in a private hospital for almost a week. Child referred to us for persistent fever and thrombocytopenia. Since there was the Down species, bicytopenia with relatively high WBC count, and the persistent symptom, we went ahead and did marrow. Marrow showed acute myeloblastic leukemia M5 with a flow showing CT30 1333 positivity. This child also had KMT2A rearrangement by FISH, which is again a poor prognostic marker for pediatric AML. So Down's child with KMT2A positivity with AML. So again, it was a very difficult case for us to treat. In pediatric patients, we usually start with 7+3 induction. So again, we did the same thing for him. For TLS, we started him on IV fluid and allopurinol prior to induction chemotherapy. But unfortunately, on day +5, the child developed severe respiratory distress with mucosal bleed, which required multiple platelet transfusion. The child also had Klebsiella pneumoniae, which was treated with IV broad spectrum antibiotic. Child was on ICU during this time. On day 28, child continued to have severe thrombocytopenia, neutropenia, no hematological recovery. On day +42 also, the bone marrow still showed profound suppression. So this child was in intensive care unit at least for 1.5 months. And it was really very troubling for us to take him out of the ICU care. So fortunately, after 45 days, the child responded well and started improving. But we discussed with the parents and they denied giving any kind of high intensive chemotherapy. So we had discussed with, and they even wanted to take the child back. So after extensive discussion and reading various literature, we discussed with them, and we thought just go ahead with AZA and venetoclax chemotherapy. So this was first time we have used this chemotherapy in such a small child. Azacitidine, we use 75 mg per meter square IV for 7 days every 28 days, which was combined with venetoclax. In the second cycle, for first 7 days, we just gave 50 mg and then we ramped it up to 100 mg. Then this regime was well tolerated. Fortunately, the child did not require admission. And after cycle 2, when we did the marrow, the MRD was negative. Though we did not have due to economic constraint, the NGS was not done, but yes, the MRD was negative, so we were very happy. So we continued with 4 more cycles of venetoclax and azacitidine chemotherapy. But again, the child had one more episode of neutropenia, which responded to conservatively with the IV antibiotic without any ICU care and support. So this was the CBC report at admission, 7.6, this one which I've already explained. And subsequently in last 3 follow-ups, his hemoglobin is in last August 25, 13.6, WBC 6050, and platelet is normal. So he's doing fairly okay in last 2 years. So I know this is very unusual because venetoclax, as cited in, as we have discussed yesterday also, you have to continue it for lifelong. But in this child, because of economic constraint, we could just give 6 cycles of venetoclax ASA. And fortunately, from last 2 years, he's coming regularly to us on follow-up with complete the disease in complete remission with normal physical and neurodevelopmental status. So while HSCT remains the definitive consolidation strategy for high-risk acute myeloid leukemia with KMT2 arrangement, but in this case, just with low-intensity chemotherapy, this child really did well and is now in remission and is really doing well. I've seen few literature regarding this venetoclax use in pediatric patient. So this we have got venetoclax, a new player in the treatment of children with high-risk malignant myeloid leukemia. So as you all know, the sensitivity varies with the mutation. So it is most sensitive in the mutations of KMT2A and NP1. So I found the answer here. I think maybe this child was having this, and that is why the child responded very well to this chemotherapy regimen. And resistant to TP53 and PTPN. Here you have to use some other agent along with the venetoclax. Venetoclax was also used in relapsed refractory AML, MDS, and other refractory diseases, along with other chemotherapy. So this is one of the study in which venetoclax is used in relapsed refractory leukemia. This is very important phase 1 trial, which all of us have read before this case, dealing with this case. Here they have used venetoclax with high dose cytarabine plus minus idarubicin in 38 patients of age group between 3 to 22 years with the median age of 10 years. And the dose they have used was 360 mg per meter square. They have achieved good complete remission, that is 70 to 80%. This is another very good case study in which venetoclax was used for acute myeloid leukemia in pediatric patient from Texas Medical Center. Again, this was also used in relapsed refractory setting where the survival is anyway very poor. It is less than 40%. Venetoclax, it is a BCL2 inhibitor, very much known and effective in adult patient, but pediatric data is very much limited. Even global data is also limited. So this retrospective study evaluated venetoclax use in AML patient between the age group of 0 to 23 years. So they have included infants also. In this, 46 patients were identified, and mostly they were all relapsed and refractory. So venetoclax was combined with hypomethylating agent, that is azacitidine or decitabine, and the complications, the toxicities they have found was febrile neutropenia in 41%, neutropenia in 35%, thrombocytopenia 33%, and anemia in 20% of the cases. There was no patient who discontinued therapy due to any kind of adverse events. Overall survival after cycle 1 was 53, with 42% achieving complete remission with incomplete hematological recovery, and 56% of those were MRD negative. So such an excellent response they have got even with the relapse and refractory cases. 37 patients successfully proceeded with bone marrow transplant. Some of the study which we have reviewed, in which all these study, these are all very small cohort of patients ranging from 5 patients to 38 patients. They all used venetoclax in different doses. So what I found was maximum in 2 to 3 case series, the dose used was 240 or 360 mg per meter square. They have used for 28 days. Median cycle like around 2 to 3 cycle, and then all patients were proceeded for bone marrow transplant. It was never used as a single as an isolated strategy. Every child was then proceeded for bone marrow transplant. So combination this was venetoclax was used along with the combination chemotherapy, sometimes with cytarabine and idarubicin, and in some cases they have used with azacitidine. So this is a very good series of studies for pediatric patients. If you summarize all these studies, complete remission rate ranging from 37 to 92%. In frequently, it is used as a bridge to bone marrow transplant. And the best part is post-transplant survival outcome, which is 50 to 70%. As we all know that in pediatric patient, even after bone marrow transplant, the survival rate is still very low. It is 50 to 60 hardly, especially in relapsed refractory setting. So here it is even better, and it is significantly better as compared to the patient in which this venetoclax was not used. So definitely, this is going to be a very good strategy, especially for pediatric patients in future. But though the data is still limited, so where it fits, actually, it is more sensitive, as I have already said, KMT2A rearranged patient and NPN1 mutation, IDH mutation. In these patients, they are going to respond very well to venetoclax and azacitidine therapy. TP50, PTPN has to be combined with some other therapies. And FLT3, you all know, better if combined with FLT3 inhibitors. Key message is, with this case, venetoclax was well tolerated, showed promising activity, though upfront use, optimal pediatric dosing, long-term survival benefit, it requires further study. We still do not have answer to these questions. We need to work on Indian data, which is seriously lacking. We need to work on retrospective data. Like our case, we have to club all these cases and make a pool and publish this, and a prospective data on its use in Indian children, especially infants where survival is poor and toxicity is very high with induction chemotherapy. Especially the small infants, many kids, they do die during their induction chemotherapy. So we really need some kind of alternative to bridge them to transplant. Another interesting case, a 2-year-old girl with against Down's phenotype only. This girl brought to us with high-grade fever for 3 weeks, progressive pallor and weight loss. There was pallor present. There was no organomegaly. There was continuous murmur on auscultation. There was no bleeding, seizure, jaundice, or previous hospital admission. Development-wise, the child also had global developmental delay, which makes difficult for us to treat. But there was no prior cardiac intervention. Basically, the child was referred to the cardiology department for her PDA management. But in pediatric cardiology, they found that CBC showed a very abnormal features like hemoglobin was 7.8, TLC was 11,000 with 68% lymphocyte, platelet count was 58%. There was no atypical cell on peripheral smear. There was mild transaminitis with marginally elevated LDH. So echo again showed 6 millimeter PDA with left to right shunt. So my cardiology friend, they called me for thrombocytopenia. They asked my opinion for thrombocytopenia. Since this was some abnormal peripheral, we re-looked the peripheral smear. So we do see that there are some peripherally abnormal atypical cells. So we went ahead with, and the child already had Down's phenotype with high risk of leukemia as compared to normal non-Downs patients. So we went ahead and did marrow, and we found that marrow showed hypercellular marrow with more than 80% blast. Flow was suggestive of precursor B-cell ALL with negative myeloid marker. Molecular and karyotype fortunately was normal. So the child was started on induction chemotherapy protocol. Since this child has Down syndrome with cardiac problems, so we did not give anthracycline. We just went ahead with prednisolone prophase, vincristine, and asparaginase. But on day 8, the child developed CCF and required ICU admission. We had to stop the chemotherapy at that point, continued with steroid. Child was stabilized with diuretic, oxygen, and other careful fluid management support. Again, shifted back to cardiology department because we knew unless we don't solve this PDA issue, we are not going to continue the chemotherapy. The child is going to go worse. So spoke with the cardiology friend, and they immediately took the child for PDA ligation after extensive counseling with the parent. Fortunately, the child survived the procedure well. Post-surgery, chemotherapy was reintroduced in a risk-adapted manner. The child tolerated consolidation and maintenance phase well without any unplanned hospitalization. This child has recently finished his chemotherapy, and the child is doing well. He just came to us last week only, and he is completely all right. In fact, he's also doing well in terms of his neurodevelopmental growth. So that's what the case was, a very interesting case for us to deal with. So ALL in Down syndrome, I think it is very important for us to understand. Children with Down syndrome have really increased risk of precursor B-cell ALL. Historically, they have inferior outcome, higher risk of relapse, higher transplant-related mortality. Prognostic impact of genetic abnormality is still unclear. So this is a very good retrospective analysis by PDL group. They have pooled many data from 16 cooperative group trials from 95 to 2004. 653 children with Down syndrome were compared with 4,445 non-Downs patients, and they have evaluated event-free survival, overall survival, and transplant-related mortality. They have also assessed the cytogenetic and molecular characteristics. This is very important for us because we really have no clue about the management of Down syndrome. It is always vague. So this is very good slide. Usually the risk stratification is NCI based, where age less than 10 year in children and WBC less than 50,000 is called as good risk, whereas opposite, if age more than 10 and WBC more than 50,000, that is called NCI high risk. But here, after pulling this data, they found if the age is less than 60 years and WBC count less than 10 years, it is an independent good prognostic marker, along with this ETV6 RUNX mutation and high hyperploidy. This was the result they have found. So the patient who had age less than 6 and WBC less than 10 years, their event-free survival is as good as our normal non-Downs patient, which is 78% and 87%. So this we need to keep in mind. So if you want to risk stratify and you want to tailor your therapy, you can keep this thing in mind and do your alteration very well. So cytogenetics and molecular abnormality also they have seen. So they have found 40% had normal karyotype, 8% has ETV RUNX positive, 9% high hyperploidy, 60% CRLF rearrangement, 20% JAK mutation. But CRL and JAK mutation prognostic impact is there's not independent prognostic markers. Then outcome comparison they have done Down syndrome versus non-Down. So this is very good overall result which we found. So Down syndrome, as compared to non-Down patient, has almost 15 to 20% lower event-free survival and overall survival. But relapse risk is relatively higher and transplant-related mortality is relatively higher when compared with the normal non-Down patient. So this was a very good data for us to prognosticate. And whenever we have a child with Down syndrome presenting with ALL, we can have this data and have a conversation with the parents. The key message is Down syndrome in ALL has a poor survival primarily due to relapse. Treatment reduction is not generally justified, only in few cases which the age is less than 6 and WBC less than 10,000, hyperploidy and ETV RUNX mutation. Focus should be on improve supportive care because Down kids, they have multiple comorbidities. So before you start the treatment, please get extensive evaluation of echo, USG finding, any other morphological abnormality or any other organ specific problem. So please sort out those issues before starting the chemotherapy. Risk adapted therapy only for favorable subgroup. Development of Down syndrome specific national and international protocol. This is very much needed in today's scenario, especially in Indian settings. Good prognosis subgroup we have to classify with ETV, RUNX and hyperploidy with trisomy 410 positive. They may benefit from treatment reduction. Another important case and very difficult case for us also to treat. This was a 10-year-old girl brought with waking up with acute onset upper facial swelling, vomiting, cough, fever for 4 days, and sudden onset respiratory distress. It was just from past 48 to 72 hours. When the child brought to the emergency department, X-ray and echo was done. There was large pericardial effusion. In fact, in ICU only, emergency ICU, pericardial tamponade, and for tamponade, the draining was done. So this child was not only having the effusion, this child also had pericardial tamponade. Since the child was very, very sick, so could not be taken up for CT scan, pericardial fluid was, centrifuge was done. This was the X-ray of the child. Hemoglobin CBC showed hemoglobin of 8.7, TLC 3,400 with relatively higher lymphocytes, platelet 1.2 lakhs, albumin was okay, LFT, RFT was normal, ESR, CRP was high, urine analysis was negative. So intensivists were wondering about the cause of pericardial effusion. Pericardial fluid was sent and they asked our opinion for this abnormal CBC report. Since the child was very, very sick, so nothing could be done. We just asked them to send the pericardial fluid for flow cytometry. Other things were normals, ADA, CBNAT, ANA, everything was negative. Child required repeated drainage for his respiratory to resolve his respiratory distress. Eventually, CT scan done, which showed anterior mediastinal mass. But again, since the child was very sick, hand could not be biopsied. Fortunately, on pericardial fluid analysis, we got 84% blast with T cell lineage positivity, 237 positive. So we diagnosed this child as T cell ALL and then started on supportive care and maintenance, induction chemotherapy. Again, IV antibiotics started because the child was very, very sick. Hyperhydration, we just titrated the fluid along with Lasix infusion and other supportive care with careful pediatric cardiology monitoring. Started on induction chemotherapy. Initially, we did not give first day 8 of anthracycline because the child was sick. We just continued with Profase, prednisolone, vincristine, and asparaginase. Swelling again worsened over the next 48 hours, and then eye again nearly was closed. So this time again, the child was required pericardial fluid drainage. Then eventually by day 8, there was resolution of facial edema and the child started improving. Fortunately, this child is also well and he's on maintenance chemotherapy. So this was a very good example of multidisciplinary care where we involved pediatric intensivist, cardiologists, and the pediatric cardiology unit team. So we all really worked hard to save this child, and fortunately we could do that. So there was some case report of children presenting with cardiac tamponade. Effusion is okay, but tamponade is little rarer in these children. Effusion and the T cell ALL usually in pediatric patients, they tend to present with mediastinal mass and effusion. But tamponade was the first presentation for our unit. So again, this was also a case report where 10-year-old boy presented with dyspnea and hypotension. Massive pericardial effusion with tamponade. CT showed anterior mediastinal mass. Flow cytometry was positive. Again, managed with emergency pericardiocentesis. Induction chemotherapy was started. This child achieved remission and remained disease-free on follow-up. Another 8-year-old child presented with dyspnea and facial puffiness like our child, medius channel widening plus large pericardial effusion with abnormal echo, diagnosed as T lymphoblastic leukemia, lymphoma, treated with multi-agent chemotherapy. Again, there was rapid resolution of effusion and sustained remission was reported. This was one more case report. I have just seen in elderly again, it is very, very rare in adult patient also to have cardiac tamponade. So these are the two case reports which I could find, because most of you are adult hematologists, oncologists. So I thought it is worth talking about these two cases also. 72-year progressive dyspnea with fatigue, normal WBC, hemoglobin 13.8, mildly increased BNP, imaging for bilateral effusion, pericardial effusion, the mass encasing major thoracic vessels, and echo showed tamponade with the respiratory distress. The emergency pericardiocentesis was done. The fluid, again, cytology showed T-cell lymphoblastic leukemia, lymphoma, resolution of pericardial effusion on follow-up imaging, and there was good clinical improvement. Another woman, 52-year, with prior breast cancer, treated again with chemoradiation for breast cancer, eventually presented for 1 month dyspnea, tachycardia, night sweat, WBC was high, blasts were there. This lady presented with large anterior medial channel mass, again encasing vessels with pleural effusion, required pericardiocentesis for tamponade. Flow suggested precursor T-cell ALL, underwent surgical pericardial window plus medial channel mass biopsy, and then eventually started on hyper CVAD, which is a salvage chemotherapy, and proceeded with allogenic bone marrow transplant. So the key message here is pediatric T-cell lymphoblastic leukemia presents with medial channel mass. Pediatric T-cell ALL, as I said, it is rare. Almost 20 to 30% out of them, 50% presents with medial channel mass. Effusion is seen in 15 to 25% of the cases. But pericardial pleural effusion we had seen earlier. Presenting with tamponade, for us, it was first case, and it is very, very rare. Diagnosis is still a very challenging thing for us, especially in critical cases where you cannot do biopsy, child is sick, you have to save the child by some mean. But in such cases, definitely, if you talk to the intensivist and immediately send flow cytometry from a pericardial fluid, it is going to really change the picture. So early drainage and prompt chemotherapy can improve survival in these patients. The last case, a 6-year-old boy presented with undisplaced fracture of the lower end of the tibia following trivial trauma 6 months prior, developed severe lower limb pain and backache, eventually becoming unable to walk and bedridden. When the child brought to us, usually in such cases in pediatric, whenever they have multiple fractures, we always think of osteogenesis imperfecta. We also thought of tuberculosis, some metabolic bone diseases, MPS, but that everything was normal. All workup was normal. There was no alternative diagnosis which explained this persistent bone pain. The child was initially admitted in orthopedic department, and the pediatrician were also looking after the patient. But in view of generalized osteopenia, multiple fracture, multiple unusual fractures, and this kind of CBC, which we see over a period of 10 days. So in initial presentation, this looked absolutely normal. Hemoglobin 10.8, total count 6,900, ANC 3,200, platelet count 1.85, and no blast. So eventually on day 4 also there was some changing picture, but day 10 they asked our opinion when HP dropped to 7.2, TLC dropped to 2,800, ANC 850, platelet count 48,000. So this is very important message. One CBC picture cannot rule out anything. You have to see the serial CBC, and over and above, you have to see the serial lymphocyte and the neutrophil count. So this child, we did marrow. Marrow showed B-cell ALL with more than 90% blast. Karyotype and molecular was normal. The child demonstrated an early favorable response. On day 8, achieved complete molecular remission by day 28. And now the child is in complete remission and following us with for maintenance chemotherapy. So the key learning from this case we got was a single normal CBC can never rule out leukemia, that we all know. Trend over time are far more important than isolated value. This I don't think we all need to learn, but we need to teach this to everyone, whosoever is working with us and other areas, that please see the CBC carefully whenever you have some unusual cases where diagnosis cannot be established. So how common it is? At diagnosis, 5 to 10% of children may have near normal WBC at presentation. Hemoglobin platelet count can initially be within normal limits. True, completely normal CBC is usually uncommon. If you carefully see, there could be some unusual lymphocytosis or low platelet, low HB, some pancytopenia. So these kind of initial picture you could see, but it is difficult for us to diagnose at this moment. Large pediatric ALL series, including COG and European group, they have also reported a rare presentation. Pattern across cases which we see, normal or near normal CBC in almost all cases, organ specific symptoms, misdiagnosis with all normal condition like tuberculosis, then metabolic problem, hyperparathyroidism, so on and so forth. So there could be multiple diagnoses with one single condition. Treating cytopenia, people has treated like nutritional anemia, kept on giving iron, folic acid, B12, and then turned out to be leukemia, which is also not uncommon. Assuming infections or TB, like severe sepsis or tuberculosis, and then again waiting for blast to appear on the peripheral smear. Red flag signs are bone pain, unusual fractures, persistent malignant hypercalcemia with no cause identified, so on facial edema with no cause identified, renal failure, unexplained cytopenia. So these are all very important red flag signs. When to do a marrow, I don't think in this audience I need to tell. Persistent unexplained cytopenia symptoms, unexplained symptoms, sorry, bone pain with normal counts, metabolic rearrangements, and organ infiltration. So whenever you see symptom persisting for a long period of time, something unusual happening, abnormal CBC, and I think we all can identify anything abnormal in CBC, but all kids, they don't present to us. They present to sometimes cardiologists, neurologists, intensive care experts, or physicians. So the diagnosis may be delayed. Take home messages: leukemia is a master mimicker. Normal CBC can never exclude leukemia. Bone marrow should not be delayed whenever you have suspicion. Early diagnosis reduces the complication and can give excellent outcome. So this is our team. I would like to say my thanks, sincere regards, and thanks to my team of doctors and nurses who helped us in the treatment of these complicated cases. And this was a picture taken during recently celebrated ICCD celebration in 15th of February, along with the head of the institute. So along with that, thank you very much, Dr. Amit Khurana sir, respected MB Agarwal sir, for this great opportunity. I hope I'll get that again. Thank you very much. And I can answer the question now. Thank you, sir.
Thank you, Dr. Shweta Patak. Wonderful cases, really eye-opening cases, and what a flow it was. Thank you so much. I now request our discussants to please put hand raise signs so you can start questions with Dr. Shweta Patak. First is Dr. Agarwal, sir. Please go ahead, sir.
Thank you, sir. Sir, I just want to say one thing. I really want to say that I started hematology because of you only. I have heard your lecture in one of the conference when I was a resident. And then I thought I'm going to opt for hematology only. But I was in pediatric wing, so I just wanted to continue with pediatrics only. So thank you, sir. You're really, really a role model for us.
Thank you. Wonderful case collection and beautiful presentation. Thanks for bringing all this to us. I have a little philosophical question. In our days, there were no pediatric hematologists, so we used to treat all the children with pediatric acute leukemias. I'm talking about 70s, 80s, 90s. Now, many of them have grown up, and we see problems related to their mental faculties, IQ, memory. We see avascular necrosis of the bones, especially the hip. We also see the cardiac damage and all that. Today, what precautions do you all take? One thing, of course, which has become obsolete is the cranial radiation, which has helped, but remaining things probably still exist. And the second question I have is 90% of children with ALL are cured. What can we do to cure the remaining 10%? Your philosophical thoughts.
Okay. Thank you, sir. Thank you for this wonderful question. Sir, to answer your first question, I think the long-term follow-up is very, very important. So, other than that, development, because most of the kids, they are usually in early age group, less than 5 years. And during that time, the brain development is happening. Usually nowadays, the radiotherapy is almost like used only in cases of CNS leukemia, positive cases. And we also use, as per BFM protocol, ALL with more than 1 lakh count. So in my own cohort of 140 patients, only 10 kids, they required radiation therapy. All kids have, they just continued with chemotherapy, and they all are doing very, very well. So I think this is the same result which we got from every institute. So that is is one thing, that role of radiation has come down significantly in pediatric population. And even with that, we are getting a very good result. Long-term follow-up is very important. So we also ask them to go for bone densitometry test because they received a long course of steroids. So bone densitometry we do at least for first 5 to 6 years of the follow-up. And other than that, we have a psychologist and the nutritional specialist. So they also tend to come for a regular follow-up visit so that they can be counseled in each and every visit. So that is how we are looking after the cases. But adolescent children, there is a problem because after 18 years, we don't see these kids. So we used to hand over these cases to our adult oncologists, and I think they also used to do well only. And we used to tell them we have a file in which we write what are the kind of doses the child has received, how much dose the child has received, whether the child has received radiation or not. So that kind of booklet, it will be there with the patient. So even if they go to adult oncologist, they carry that booklet. So with that, they can find out what was done and how to look after this child well. And whenever they have doubt, they can talk to us. That is one thing, sir. And how to save remaining 10% cases. I think, sir, first and foremost thing is, sir, the most problem, still the number of pediatric cardiologists, oncologists is very, very limited. In our whole Madhya Pradesh, we are hardly 7 or 10 total. If you include the whole Madhya Pradesh, in my own city, I'm the only pediatric oncologist here. So most of the cases, they used to come to me when already the count is 1 lakh, 2 lakh, 3 lakh. So I think if you really want to make the change, we need to work on early diagnosis, and we need to sensitize the physician, the peripheral doctors, medical officer. We can also take use of these ASHA workers who goes to the periphery and peripherally posted medical officer. So they need to be trained because it is no more a rare disease. Earlier, in last 1 year only, in this small region, we have diagnosed more than 150 children with cancer. So now the time has come when we need to outreach our approach, and we need to incorporate each and everybody, the stakeholder, to diagnose these cases on a very early age. So once they come early, I don't think the management is difficult. I've seen huge difference when you start with pancytopenia and when you start with high WBC count. Definitely the outcome is very, very different. And in fact, the overall morbidity, whenever we start with pancytopenia, the chemotherapy, once we start, the remission is very fast. There would be good prednisolone response. The MRD will be negative. Post-induction MRD will be negative. Whereas if you start with high WBC count, there is a risk of TLS, multiple complications. They go to the ICU. So even though we would be able to save them, but yes, they can die of any kind of morbidity during induction. So I think early referral is very, very important. And key point messages, I think all stakeholder and all the peripheral workers, they need to come in the picture, and they need to be trained regarding early diagnosis of these small cases, which can be saved. I hope I've answered the question, sir.
Thank you. Thank you.
Thank you, sir. Thank you, Dr. Shweta. There is one question from Dr. Emon Tent. Your opinion, current treatment choice decision for pediatric inspired regimen versus hyper CVAD in high risk adult and youth ALL.
Hello?
Yeah.
Sir. So in pediatric patients, sir, hyper-CVAD, we have used only once in a refractory setting. And I think that side also we lost. So we usually, whenever we have a child with relapsed leukemia, our protocol is, we go by LLR3 protocol. That is also like a small induction, 4 weeks ka induction with dexamethasone, intermittent 7 days, then along with pegasparginase, daunorubicin, and the supportive care. So we follow this LLR3 protocol. Mitosentron we don't use because this is our whole modification. Mitosentron we have used initially in 2 to 3 kids, they all died. In fact, when I was doing my training in Narayana for my fellowship FNB, that time also we have lost many kids due to mitosentron. So we have modified and we have used daunorubicin instead of mitosentron. But with this ALLR3 protocol, we have got good response, and I think 3 cases which went into remission, and then we have done bone marrow transplant for them also. So I think ALLR3 is a good protocol. Hyper-CVAD I've used only once, so I have limited experience, and that also I have lost.
Okay, thank you. Still the second speaker is not taken. I'll take 1 or 2 more questions.
Just add to the answer.
Yeah.
Dr. Thunt has been asking about pediatric inspired regimen versus hyper CVAD in high risk AYA ALL. So what we do is that in younger patients, and your AY, AR or younger patients, go for the pediatric inspired regimen. And for elderly people who are beyond 50, we go for the hyper CVED, either mini or full blown.
Yes, sir.
Thank you, sir. Another question is from Dr. Manoj. How to manage coagulopathy with thrombosis in acute promyelocytic leukemia? Should we give FFP cryoprecipitate if required and continue along with anticoagulation?
So in this case, our case where the child was presented with thrombosis, so we initially gave anticoagulant for first few days because that time the even diagnosis was also not clear. So we started with enoxaparin. And then we also gave after 3 days once we got the diagnosis, we have done D-dimer fibrinogen. So actually for that case the child was in ICU, so we gave FFP BD and intermittent cryoprecipitate. After 7 days, when the child was well, the counts was started improving. That time we have stopped the cryoprecipitate and FFP. So we follow this platelet count protocol because platelet count is very very important. Once your platelet count becomes static, it is very easy. You can stop using your FFP cryoplatelet because that time the risk of bleeding is very, very less. So in all APML patient, for all practical purposes, you have to change the platelet count and fibrinogen level. So these two things, if you follow, I don't think the managing APML would be difficult. We have 7 APML cases and all of them we have seen the same thing. So platelet is important. For initial part, you can use anticoagulant. I think that will work. But eventually when you diagnose the condition, you focus on the specific therapy rather than focusing on bleeding and thrombosis.
Thank you. Another question is Dr. Priyanka. Which is the anticoagulant choice in pediatric apart from LMWH?
Actually, we use enoxaparin only. But yes, oral anticoagulant you can use in other condition, procoagulant disorder, protein C, proteinase deficiency. So there we use rivaroxaban and other oral anticoagulant. I mean, the results are equivalent to adult. There is no such difference. So the reported data is not very assuring. But yes, it is used. It is your oral anticoagulant you can use if you want to use it for a longer period of time. So yeah,
So if you're
but
using
not
yeah.
in malignancy, not in malignancy.
So if you're using rivaroxaban, then what is the dose in pediatric patients? Dose of rivaroxaban in the pediatric patients?
Actually, adult only we have used. Dose is similar to adult only. I don't actually remember the dose what I have used, but it was like adult dose only. I exactly really don't remember the days. It was adult dose only we have used because that was also an adult child, adolescent patient.
Okay. So there are no more questions. Sir, you have any other question? Because our next speaker is not joined yet.
Next speaker has just informed that he's having some technical difficulty in joining. He will join as soon as those technical difficulties are sorted out. So any moment he'll be with us. Yes, Dr. Shweta, can I drop you
I have a question for you, sir. Actually, if I can ask.
the other way? Okay, go ahead.
Sir, in earlier days, MCP protocol, MCP 841 protocol used to be used like in your days. In our system, some radiation oncologists outside the medical college, they still use MCP 841 chemotherapy, and as per them, it is the results are good, equivalent to BFM protocol. So, how to how to counsel them? And I've repeatedly discussed with them that this BFM protocol or ICICL protocol is Indian protocol that you have to use. So how to counsel these people, sir? They keep on arguing with us, and since I am very young as compared to them, so they don't agree with my point, and they continue to use MCP despite having poor result. They don't accept it. So how do you deal with such conditions, sir?
Well, there are two things. One is a question of survival. So everybody does everything despite availability of the specialist. For example, now with pediatric hematologist, oncologist, we adults have stopped treating pediatrics. The radiation oncologist should now believe that medical oncologists, pediatric oncologists, hematologists are around and they are superior in their knowledge, their approach to the patient's cure, and they should probably restrict to their own problem, but it's a question of their survival. Second is, as you mentioned, in the whole of MP, there are only 7 pediatric hematologists, oncologists. Like that, there are many remote parts of this country where radiation oncologists exist, but you and me don't exist. So they are forced to treat, but they must update themselves. We used to give cranial radiation, as you mentioned, in 70s and 80s, but the moment high-dose methotrexate was shown to be superior, last 30 years, we haven't given cranial radiation except for the condition that you mentioned. Radiation oncology should also take all this into their purview. It's not one day goal, but yes, you and me have to keep teaching. And one of our part is teaching. I hope radiation oncologists join us, listen to us, and follow us.
True. Thank
Thank
you.
you, sir.
Dr. Deep, you have a question.
Uh, Thank you, ma'am, for this wonderful case series. Actually, I have a question regarding pediatric pH positive BALL, ma'am. So, if the child is RQ-PCR, BCR-ABL positive post-induction, post-phase 1 induction, and also positive at day 60, but becomes negative by around day 100, and no other complex karyotype features, no other additional genetic mutations, but meanwhile, you have done an HLA typing and there's a presence of matched sibling donor. So, ma'am, in this scenario, do we offer transplant in the CR1 for this child, or how do we approach this scenario? Persistent BCR-ABL positivity after two phases of induction, day 60, but becomes negative at day 100.
Yeah, hi. So, in our risk stratification, BCR-ABL is classified as high-risk case in pediatric patients. So, ideally, in all patients, pediatric patients also, you have to go ahead with bone marrow transplant if the child is in complete remission. But there are some cases which says that if you've got good molecular response, if BCR-ABL is negative, some people have continued with maintenance chemotherapy along with TKI inhibitors. And then the children, they have also done well on regular follow-up. So, but in general, I think BCR-ABL positive, you have to take the patient for bone marrow transplant once the child has achieved remission, because this child is having very high risk and is going to go relapse when we don't know. So, if you have donor available, if the parents agree, there are multiple things which plays a role in transplant. It's not just the indication which matters. For example, in this case, BCR-ABL positivity. It also matters how ready the parents are, first and foremost thing. Second, what is your facility available in your place? And is the patient is ready to move out for getting the transplant done or not? So all these plays, sometimes you just counsel the patient, you ask them to go, and meanwhile they stop the therapy. And transplant is not a one-day job. You have to extensively evaluate for donor workup and everything. So these are all important things which plays a role. So my suggestion is continue the therapy, counsel the patient with everything is favorable, like donor is available, facility is available, indication is there, you're also ready, your team is ready, then please take the patient for transplant.
Sir, your
Thank you.
Just want to add, Dr. Deep, you should look at the Icarus gene mutation. If that gene is mutated, then irrespective of the response, patient must be transplanted. If that is negative, and the cases like what you discussed, there is no complex karyotype abnormality, there was a quick BCR-ABL negativity, both molecular as well as by flow. And if this patient is ready to take a potent TKI post-maintenance for a period of minimum 3 years to 5 years, then there are patients probably who can do as good as without transplant. Availability of a donor, type of donor, all those factors are important. But Icarus gene makes a huge impact in the outcome of the patient. If it's mutated, medical treatment will not work.
Thank you so much, sir. Thank you, ma'am.
thank you, sir.
Thank you.
So our second speaker has come. Dr. Leto has just joined. Sir, we already
Yes,
speak to you.
yes.
Welcome, sir. A very, very good morning to you. And we were just exciting to listen from you. Yes, sir. So you can share your screen.
You have already been introduced. You can go ahead, sir.
Yes, sir. Sir, you can share your screen now, and you can start your presentation, sir. We already introduced you already, sir.
Also, you are muted.
Is it working now?
Yes, sir. Full screen mode, sir. Yeah. Again,
And
sir,
now it's okay?
we cannot see your screen. Again, sir, you need to share your screen, sir.
There is full of problems with flows here. Anyway, trying again. Now?
Yes.
And now it's working?
Gone.
Yes?
No, gone.
Okay, so I have to stay like this, right?
It's disappeared. You have to again.
Okay, so I cannot put full screen. Is it here working?
It is there.
Okay, so we'll do this way because I mean it's already a good thing that you can see my slide. So thanks a lot. So sorry for the delays and being late. As you know, we have some flows problems in France, and I got completely blocked and stuck and cut it with electricity. So basically, now it's working. So I would just speak about emerging therapies because. I guess I did already a talk on treatment, and the idea was really to update you on the main issues that we have at the moment with PNH and how we could take care about our patients according to what has been published and basically where we are because the field is advancing quite quickly. So if we are speaking about PNH, you know that we are going to speak about a disease that is associating a triad. This is acquired hemolytic anemias, aplastic anemia and thrombosis. And basically, what we do know is that before complement inhibition was available, the median overall survival was about 22 years. So it means when a patient was diagnosed at 30 years of age, then he got thrombosis as a main complication and possibly death before the age of 50. So this is a very rare disease. We have about 1,000 patients that has been diagnosed in France in the very beginning. This is a disease that has been revolutionized in the last 20 years with occurrence of complement inhibition and more recently the proximal treatment. So what I would speak about is about of terminal complement inhibition, which we know very well and now is a bit, I would say, the past. And then we'll go for proximal inhibition. And the idea was really to speak about the recent publications and what we have feared about according to proximals, essentially because you know that those patients might be exposed to complications, and that's what I would like to explain because this is something that we did not understand very well at the beginning. So first of all, complement terminal inhibition is very easy to understand. This is something that we have published extensively, and basically what we do know is that we can block complement at the terminal level, and we are avoiding complications such as hemolysis, thrombosis, protecting patients. And what we do have as treatment is mainly eculizumab and now ravulizumab. So ravulizumab is a treatment that we are now using since 5 years. The results are very, very good. It's exactly the same than eculizumab. So as you see here, ravulizumab is a monoclonal antibody that is directed against C5. And the good thing with ravulizumab is that there is a recirculation according to the pH of the monoclonal antibody. So basically, in the blood, the antibody is fixing the C5, and then the antibody fixed with the C5 molecules is couched by the reticular system, and there is a recirculation. And since there is this acid pH, then there is a dissociation between C5 that is degraded and the antibody that is recirculating. So as you can see, there is a very well controlled, this is a very long-term follow-up of the patients under ravulizumab. And as you can see, the control of intravascular hemolysis that is really highlighted by LDH. LDH is the main marker of intravascular hemolysis. You see that the intravascular hemolysis is perfectly controlled. There was a well control of the major adverse vascular events. So in other words, there is no more thrombosis. We do know that in patients under eculizumab, the rates of thrombosis is about 4%. And in that condition, this is exactly what we got with ravulizumab, while before, again, the rates of complications of thrombosis was about 50%. So as you can see here, ravulizumab is well tolerated. Ravulizumab is controlling intravascular hemolysis, and ravulizumab is basically improving significantly overall survival compared to patients in the registry, the IP registries, in the international registry, controlling and able to improve significantly overall survival. So this is a study that we just published with Austin Kulakaseraraj, and we were again looking on a high number of patients who are treating with ravulizumab, and basically what you do see is that the safety is absolutely great, and that was what we got for patients since 20 years. That was an amazing progress because basically the patients are now controlled with thrombosis complications. They are doing, of course, better. They're back to work. However, what we do know is that the mean hemoglobin level of a patient under ravulizumab is about 10.8 gram per deciliter. So there is still a patients who are anemic, and that's in a way a problem because they're experiencing fatigue. So we do know that when we have a patients under complement inhibition, we do know how to explore this anemia. And basically, as you can see here, this is what we are doing. We are first of all looking for reticulocytes. And if the patient is presenting under complement inhibition, a no regenerative reticulocytes are low, then you must look on other causes of possibly anemia, like, of course, carences, kidney dysfunction, especially because those patients have been exposed to long-term iron deposition. It might present kidney dysfunction. Of course, thyroid dysfunction, marrow aspiration has to be done because they can be exposed to clonal evolutions such as MDS and AML. And that's something that you should think about. On the other way around, you have some patients who are still anemic and have high rates of reticulocytes. And that's exactly what I'd like to speak about with you today, is basically those patients are presenting mainly what we call extravascular hemolysis. So in other words, now that ravulizumab is given by milligram per key, so in other words, you have a dose that might be increased, but there is no way to ask the dose of ravulizumab. Eculizumab was a constant dose. The patients were receiving all 900 milligrams. For ravulizumab, it's a different topic because there is a dose per kilogram. So it might not be a problem of treatment dose, but on the other way around, what we identified was about 10 years ago that in those patients, we are creating another disease, what might give anemia and might be treated with proximal inhibition. So in other words, as you can see here, this is a very schematic description of the complement activation. And what we do know here is that you see that if you are blocking at the C5 level, basically you are not avoiding the early activation of the complement, and you are not avoiding the C3 deposition of the cell surface. And as you can see here, it's very tiny, and I'm sorry because I cannot put in full screen for technical problems, but you see that there is some very green spot on the level of the cell surface of the red cells. And basically, when you're under C5, when you're under terminal complement inhibition, you are opsonizate, you have an opsonization by C3 of the cell surface of those cells. And what we know is that this opsonization is responsible of what we call the extravascular hemolysis. So in other words, the cells that have been opsonized are now taken in the spleen and liver by the reticulocytes by the macrophages, basically. And those cells are destroyed and responsible for a anemia in patients. That's what we published. It was already some time ago. This is 160 patients, hemolytic ones, PNH treated with terminal inhibition. And as you can see, 6 months, 12 months, or even in the last 6 months of follow-up under C5 inhibition, you see that those patients are presenting for 40% of them, about 38.6%. They are presenting, they're still transfused and anemic. So that's an issue, because you have some patients, as you can see, that are still transfused, they are still anemic, they are still experiencing fatigue while they are treating with a ravulizumab. So the idea, and that's the point of today, and that's really something I'd like to stress, because this is something we discovered as well as the management of those drugs. The idea was definitely to block the proximal level. See, if we are coming back a bit, you see that here you have a terminal inhibition, and basically you're creating I would say, extravascular hemolysis. However, if you're blocking at the stage of proximal, so you see a little bit higher, then you're avoiding the C3 deposition, and then basically you're protecting your cells. So it's written here, you see, we will fix the complement at the early activation, the very early activation, fixed by a proximal inhibition, and then of course we will improve the response rate. So this is here what the patients were basically experiencing on the C5. There was still persistent anemia. The patients might be transfused. Obviously, the quality of life was not that bad, that good, and of course, they were not going to work. So the three treatments that has now been accessible on the market, the three treatments that you might possibly use in that context is, first of all, C3, so the pegcetacoplan. This is a drug that is blocking C3 and again avoiding the early activation. You have iptacopan, that is an oral drug. The first one was a sub-Q drugs given 2 times per week. So an oral drug, morning and night, and in monotherapy. Both are in monotherapy. And the last one is the danicopan, so factor D inhibition, which is in association with ravulizumab. So this drug is given at the top of ravulizumab 3 times per day. So if we look now to those drugs, they are working nicely, and the aim of today is to alert you of what we can create. So here are the description of the drugs. So you have a very simple description of the complement activation. You see on the left side the C3 convertase. So basically you have a fixation of the C3b at the cell surface. Then the factor B is sticking on the C3b, and you have D, it is an enzyme that is going to cleave the factor B and make him activated. And then you have this C3BBB, you see, this C3 convertase activation. On the other side, you have the C5 convertase. So when a C3 convertase is sticked with a C3b, then you have a C3 convertase, a C5 convertase formation, and all these come from C3 convertase, C5 convertase, and then you will have the formation of the membrane attack complex and the destruction of the cell. So first of all, the pegcetacoplan is a C3 inhibitor, and as you can see, it's inhibited the activation at the very proximal level. You see in the red spot where the pegcetacoplan is inhibited the activation of the complement. So the pegcetacoplan has been developed through randomized multi-center international trial. There was a one-to-one randomization, basically patients receiving pegcetacoplan and eculizumab, and the results were outstanding. They were targeting patients with extravascular hemolysis. So here, as you can see, when the patients were randomized to pegcetacoplan in orange, you see that the hemoglobin level was normalizing, while when patients were under eculizumab, then basically you had a low hemoglobin level persistent. On the other way around, when the patients in the extension phase were randomized, were receiving, this is the aim of clinical trials, the patients might receive all the experimental drugs at the end of the day. And as you can see, when the patients were treated with pegcetacoplan, then basically the hemoglobin level was normalizing for all patients. So excellent drugs, excellent efficacy. The LDH were controlled. And what I would like you to understand is that extravascular hemolysis is not a disease per se of PNH. This is a iatrogenic effect of C5 inhibition. So in other words, if you're blocking at the terminal level, then you're not avoiding the C3 or activation, early activation of the complement, and then obviously this proximal inhibition is still working, and then this is responsible extravascular hemolysis. What we have here is totally different. We are blocking at the very, very proximal level. So there is no C3 deposition. And if there is no C3 deposition, you have no extravascular hemolysis. So in other words, C5 inhibitors are controlling the terminal activation, but obviously creating extravascular hemolysis. Proximal inhibitors are protecting and controlling all complement activation. So they are controlling intravascular hemolysis without creating extravascular hemolysis. So the results were outstanding, as you can see here. Intravascular hemolysis was very well controlled, LDH were normal, reticulocytes were going down because the hemolysis was controlled. And as a consequence, if you're increasing your hemoglobin level, patients less transfused, then obviously you're improving your quality of life. However, and that's the main message of today, what we did see at the very beginning is, as you can see here, there was 6 patients who needed to stop the drugs because of massive breakthrough hemolysis. And that's something that I would like you to understand, because we made some time to understand this, and that's outstandingly important in the management of our patients. So basically, why outside 11 patients who stopped the drugs during the clinical trials, we have 6 massive breakthroughs? So that was something that at the moment when we were living this, we were more trying to treat the patients and to manage the patients and to understand, but you'll see in a minute why was this. So what we did is we collaborate with somebody and we designed a study. We were thinking that at the very beginning, at the time of complement activations conditions, there was a higher target to inhibit by complement. And basically what happened is that the pegcetacoplan, the C3 inhibitors, were basically not able to control all the targets that was present at the time of complement activations conditions. So what we did is to design a study with Sabi, and we did see that if the patients were experiencing complement activations conditions, then you might inject 1 dose more of pegcetacoplan IV, and the other way around is, since the drugs is given normally 2 times per week, we were thinking to give a row 3 doses of pegcetacoplan sub-Q every single day, and then to come to a 3 times per week injection rather than 2 times per week. And that was working very well. This is Maura Griffin who published that trial. And what we did say is that if you're increasing the dose of treatment right away after complement activations conditions, then you might have the drugs continuing and not needing to stop the drugs, and no massive breakthrough. So this is what we did also in France. We used this management schedule, and then we retrospectively studied with our UK colleagues all patients who received this approach or increasing immediately after complement activation the pegcetacoplan 3 days a row sub-Q, and then to increase the treatment 3 times per week for 1 month. So there was 48 patients. You see that we followed the patients almost 2 years. All the patients were receiving pegcetacoplan because of extravascular hemolysis and significant anemias. And in that study, as you can see here, we confirmed the efficacy of treatment. You see there was an increase of 2.2 gram per deciliter hemoglobin level. There was a decrease in reticulocytes because we are controlling hemolysis. But more importantly, as you can see here, none of the patients stopped the drug. So in other words, all patients did not have massive breakthrough hemolysis because we were reacting quickly. And at the time of a complement activations conditions, we were doing this new schedule and activation of C3. So that's very important. The second inhibitor is iptacopan. It has been developed by Novartis. As you can see, iptacopan is a small molecule that is stick to factor B. So factor B cannot do its job. It's an enzyme that cannot cannot be cleaved by factor D. It's a small molecule. So D, it's an enzyme. And then obviously you're blocking first of all at the C3 convertase level, but as you can see, iptacopan is also blocking at the C5 convertase level because the small molecules might inhibit factor B everywhere. The results are outstanding, and again, this is not the main message of today. Those trials might be easy to read. They are targeting patients with extravascular hemolysis, randomized 1-to-1 iptacopan versus standard of care was 2/3 of ravulizumab, 1/3 of eculizumab, and then there was this extension period of treatment. And as you can see, this is the primary endpoint, increase hemoglobin level 2.2 gram per deciliter, and the other endpoint was obviously normalizing hemoglobin levels, so coming back to normal hemoglobin levels. And as you can see here, the other secondary endpoints were very classical in PNH trials. So this is the disposition of the patients, very common. The patients were well distributed between the standard of care and iptacopan care. And the results were outstanding. As you can see here, almost all of the patients had an increase of 2 gram per deciliter hemoglobin level. The normalizations of hemoglobin was about 70% in the patients who received iptacopan versus none in the eculizumab ravulizumab arm. The data has been presented as a late breaking because they were so exciting that was really impressive. And again, because you are increasing hemoglobin level in all patients, the patients were not transfused anymore. So the drug is working very well in terms of fatigue score, increasing hemoglobin level, normalization. You're coming to an almost normal hemoglobin. You can see here in green what we do observed under iptacopan versus in blue what was observed with the standard treatment. So, and this is, I would say, the most striking curve to me is repartition and distribution of hemoglobin level according to the standard, to the treatment vaccination. So obviously we followed those patients long term, and as you can see here, about 48 weeks data that has been published in Lancet Hematology. You can see that the patients who are receiving iptacopan, all patients in the trial, are definitely presenting normal hemoglobin level. That was the switch patients. Now we are coming to the patients who are receiving the treatment first line. So basically, if you are receiving the treatment first line, there was 40 patients. And again, the results were amazing with the normalization of hemoglobin level in almost all patients. There was not a randomized trial. There was only 40 patients naive to complement inhibition treated with the drugs. And as you can see, again, there was a very important improvement of hemoglobin level. There was a normalization of hemoglobin, and all patients were not transfused anymore. So in terms of safety, and that's a main message here, almost and no patients discontinued the drug. So that was outstanding. You see that compared to the first study with pegcetacoplan, then patients, at least 6 out of 13 stop the drugs because of massive breakthrough. Here, we did not have any discontinuation, and we do think, first of all, because factor B is easier to inhibit. Second, because we were probably reacting more quicker because of the experience before. And the other thing is that basically the factor B, as you saw, the small molecule iptacopan is inhibiting at the C3 convertase level and C5 convertase level. This much explains why you don't have massive breakthrough. This is the last study that you'll see, I hope soon, regarding iptacopan, is a non-randomized study who is evaluating iptacopan in patients who have an hemoglobin level of 10 grams per deciliter or more. So in other words, patients where there is no transfusions and the hemoglobin level is already high. And as you can see here, again, patients have an improvement of hemoglobin level. So it's not only working in the most severe patients, but also in the patients that have less severe disease. We had an increase of 2 grams per deciliter hemoglobin level. And you see here that the benefit is more important in the patients who have an hemoglobin level less than 12 grams per deciliter. Most of the patients, of course, achieve transfusion independence. And this is the last study with iptacopan. This is a real-world study from UK, the only one at the moment. We also retrospectively reported at ASH this year about 160 patients, French, UK, showing the same results. The drug is well tolerated, the patients are doing fine, and there is no discontinuation for the reason I was speaking before. And this is a kind of summary of all the patients exactly saying what I said before: improvement of hemoglobin level, hemoglobin normalization, and lack of transfusions. So the last treatment that has been developed soon was the danicopan. So danicopan is a treatment that is given with ravulizumab. It's an association, it's a combo. You're coming with the two drugs before. So to make a long story short, the results are the same. When you're using danicopan at the top of ravulizumab, you see that you have an improvement of hemoglobin level. And why you are doing better is, again, because you are blocking at the proximal level, so you don't have any extravascular hemolysis going on. The good thing with that treatment is that since you're blocking at the C5 level, I told you it's only used as a combo, then you might have less severe breakthrough, because if the proximal inhibitors is for any reason overdue, then overburden, then you have the C5 inhibitors that are still there, so avoiding massive breakthrough. So this is a long-term extension. Again, you see that all those proximals, iptacopan, ipsixitacopan, or even danicopan, are doing excellent results. So now in the last minutes, I'd like just to highlight again why with proximals we were observing more severe breakthrough. So this is a kind of schematic description of the complement. As you can see here, in untreated patients, you have an activation of C3 going through C5, so C3 convertase, C5 convertase, membrane attack complexes formation, and then you have an hemolysis that is still going on. If you have, I would say, eculizumab, then you are blocking at the C5 level. You see that all the molecules are blocked. You see here C5 was acting, then under complement terminal blockage, C5 is inhibited. And you see that on the right side, we are creating a extravascular hemolysis because the cells are quoted, and it's very well known here. You see in the yellow spot, you see that the red cells are quoted with C3d, and then there is a hemolysis in the spleen and the liver for that reason. So if now you're blocking at the proximal level, you see C3, so this is the C drugs I presented to you, then obviously there is no extravascular hemolysis anymore, because there is no anymore this quoting of C3. However, the intravascular hemolysis is protected, so of course the patients are doing better. However, and that's the main message of my talk today, what you are doing is that you are creating patients who have an hematopoiesis that is coming almost exclusively from the PNH clone. So in other words, you see on the left side that the clone side at the very beginning of the treatment was about 70%. And then 16 weeks after, you see that the patients who were treated with pegcetacoplan had a 94% clone size. So in other words, since you're protecting totally red cells under complement inhibition, then what's happening is that the red cells are taking off as normal cells, and the PNH clone is increasing drastically. And you see on the right side, this is exactly the same with iptacopan. In other words, basically you have a almost 100% clone size with patients under iptacopan. So in other words, when you are under proximal inhibitors, you're increasing your clone size drastically. So why it's a problem? Or in other words, why it might create problems? Because as you can see on the left side, if you have an ongoing hemolysis, an extravascular hemolysis, the blood is not coming exclusively from PNH. And in other words, that might work. You might have breakthrough, but not severe. On the right side, and I'm sorry I cannot put in full screen, you will see the animation. Basically, the entire blood of the patients is coming from the PNH clone, and the PNH clone is totally protected. And as you see, the patients have normal hemoglobin levels. So in other words, you see that the patients are coming from 13 grams of hemoglobin to possibly 6 or 7 grams per deciliter hemoglobin level at time of breakthrough. And you see that it might have a massive breakthrough in the blood. And that's the reason why we're observing those devastating breakthrough. On the left side, you see that if you're blocking by the complement C5, in a way, so you cannot see the animation, but in a way, if you're presenting a breakthrough, you have 1 or 2 C5 molecules that are unblocked. So the breakthrough will be not minimal, but at least tolerable. On the right side, what you should see, and again, sorry for the animation, is that if one molecule of C3 is activated, you have thousands of molecules of C5 that will be activated. So in other words, in those patients, when you're activating one molecule of C3, then you have a full activation of many C5 in the patients that have a red cell mass that is enormous because he has normal hemoglobin level. So that's the reason why we are coming from 13 gram hemoglobin level to 7-8 gram hemoglobin level. So you are having a massive hemolysis responsible for the complications. So basically, that's the main message here, is that as you can see, we had a very good and long experience with complement inhibitors. We had eculizumab, we had ravulizumab, and we had a long-term safety data. Those patients are doing well, they're protecting from thrombosis, they're coming from normal life. However, the main issue with terminal complement blockers is that you still have patients who are still anemic, you still have some transfusion going on in at least 40% of patients. So in the last 10 years, they have a massive development of proximal inhibitors. They have a massive development of C3, pegcetacoplan, factor B, iptacopan, and danicopan, that is factor D inhibition, at the top of ravulizumab for the later ones. However, what we do need to understand is that with those treatments, we are creating, in a way, patients have a 100% PNH hematopoiesis. So they have a red cell mass that is easy to hemolyze, that is outstandingly high. So that's the reason why when we're treating patients with proximal inhibitors, you really had to be very vigilant with your patients and to reacting very quickly if they are presenting breakthrough hemolysis or complement activations conditions, because then basically you might be exposed to massive breakthrough if you're not reacting quickly. So that's the reason why I spent some time on describing the differences when you have one molecule of C5 that is not inhibited anymore, the consequences, unless then you have one molecule of C3 that is going to activate many molecules of C5 and possibly very quickly, meaning that you might have a a very important breakthrough. So that's the reason why, and I would just speak about the last three bullets orally. That's the reason why at the moment in France, the proximal inhibitors are accessible second line. So in other words, we are not treating patients first line with proximal inhibition because of all those reasons. First of all, because there is no randomized trial in patients naive to complement inhibition using proximal inhibitors. Second, because as I was telling to you, you need to learn how to manage those patients under proximal blockers. So we consider that the physicians need some time. So if we had the patients first line, we have too many patients to be able to take care about. And third is because we do know very well the long-term follow-up of patients under terminal blockage. We do know very well that they are doing very well on the safety side. We do know what expecting. We know how to manage pregnancy. While on proximal blockers, we are just discovering the field. So that's the reason why at the moment, in France at least, we are using proximal blockers second line for patients who are presenting a clinically significant extravascular hemolysis. So those patients who are still anemic and transfused under C5 inhibition. And just to finish with the French organizations, what we are doing in France to be very sure which patient is receiving what, but I think in India it's more difficult to do because you have so more many than us, is that we have a very identified network of 80 centers that are reported to us as a French reference center. And when a patient is beginning a treatment, is presented first, then we are taking the indication all together, and then patients is being treated and followed by the network. So this is the conclusion now. Basically, we had some very devastating disease 20 years ago. Patients were not protecting the thrombosis, and basically the patients were dying from that disease. Since 20 years, we have access to C5 inhibition. We had I would say not 100%, because there is still some patients, about 4 or 5%, who are experiencing thrombosis, but we are protecting massively patients under thrombosis and increasing and improving the overall survival. And finally, in terms of hemoglobin normalization, you see that with proximal blockers, we are able to protect the patients from intravascular hemolysis without creating extravascular hemolysis. And that's a very important conclusion, because we are improving the results drastically. And with this, again, my deep apologize for being late. Again, happy to be here and sorry for the delay, and happy to take questions, obviously.
Thank you, sir.
Yeah, go
Thank you,
ahead.
sir. Wonderful talk, as always. It's always good to listen to you. It was a complete replica of what you talked in Paris. Thank you.
Yeah.
And now I request all our discussants to please put the hand raise signs. And first we have Dr. M.B. Agarwal, sir. Please, sir.
So thank you very much for this wonderful talk. Learned a lot. My question, do you foresee the medical treatment of PNH ever to become curative?
Yeah, that's a very good question. So at the moment, no. First of all, because I would say two only curative treatment we might envisage is bone marrow transplantation and gene therapy. For bone marrow transplantation, we are still having a high excess of toxicity, as you know. And even if we are not exposed to relapse of the disease, or at least very few, the mortality is about 10%, 10-15% still, which is not acceptable, obviously, in the countries where complement inhibitors are accessible. I hope that we will improve in all the techniques that we are developing in stem cell transplant, but my fear is that we might be possibly less toxic, but with treatment that are not available everywhere. So in other words, by doing some cell therapy and selection of cells and knowing exactly what you're injecting as number of T cells, a number of CD4 cells, it's something that might be very expensive and not usable everywhere. And again, we will never limit or reached a 100% safety using transplant. But that's, I would say, what would cure the disease. On the other way around, obviously, when you're saying that, we are speaking and thinking about genetic therapy. However, the problem with gene therapy in PNH is that the problem is not the disease per se, is that if you are treating the cells, you are not avoiding the patients to add this ongoing immune attack of the cells at the marrow failure. So you will treat the cells, but you won't possibly avoid the immune attack. So what you need to know is that in patients with PNH, what's happening is that in a way, PNH is an immune escape. It's like cis-PLOH when you have HLA mutations, so HLA haplotype loss. The idea of those cells is a natural gene therapy, if you wish, with an evasion and an increase of the PNH clone. However, if you're in a way doing gene therapy on the PNH cells, you will not avoid the immune attack behind, so you have aplastic anemia, and in a way you would stop the natural phenomena of immune escape in those patients. So that's the reason why gene therapy never will be used in PNH.
Thank you. I have one more question. Do you feel that periodic monitoring of the PNH clone is of any clinical significance?
Yeah, very good question again. Patients are mostly, they have all immune aplastic anemia at the background. So the typical phenomena with PNH is patients with severe aplastic anemia given ATG cyclosporin Revolade, and then the patients 10, 15 years after is developing hemolytic PNH. So I would say when the PNH clone is appearing, or if it's still is if already there, you have to prevent inform patients on the clinical signs of hemolytic PNH, abdominal pain, dark urines, and so on. And if this clone is tiny, let's say less than 10%, 10, 15%, it's good to monitor at least yearly. Once a year will help to see if the clone is increasing or no. But more than once a year is really too much.
Thank you so much, sir.
Thank you, sir. Dr. Akanksha Garg, your question.
Yeah, good afternoon, sir. Thank you for the wonderful talk. So, my question is regarding a case of mine. So, basically, a female 32-year-old, she presented with pancytopenia, and she had had 2 to 3 bouts of hematemesis in the past 1 month. So, we basically evaluated her, and there was a lot of portal vein thrombosis, and secondary to that, she had developed a hypersplenism. And further evaluation, we found that she had a thrombotic PNH. The PNH clone was 95%. So, and the marrow basically did not show any in any marrow failure was not there. It was hypercellular, normal functioning marrow. So we have a 95% clone thrombotic PNH. She has hypersplenism, pancytopenia. She was started on anticoagulation, but platelets currently, then with the low platelets, you're not able to give her continuously. So now we are planning for, because she presented to the surgical gastroenterology side, they are planning to do a splenic embolization because the hematemesis, she's constantly having that because of the back pressure changes. So my question was that in managing this kind of a patient, like do we start her with eculizumab? She has been recently diagnosed treatment naive. So I just wanted to know how to go about this particular case and how we can manage her.
So it's not an easy case for a Sunday morning, right?
Yeah.
No, this is the most severe presentations we can have. Thrombosis is still a huge problem. At least we have complement inhibitors. In your case, I will definitely, of course, pursue complement inhibitors. I would probably go for immunosuppression. We had some patients with concomitant treatment with ORS-ITG and eculizumab, and we published that the two antibodies might be used together, and the response rates of those patients is exactly the same than the patients who have not been exposed to eculizumab. The question would probably be TPO receptor agonists in that particular situation. Of course, you are thinking you may increase the risk of thrombosis recurrence. So what I would do is probably go for eculizumab with immunosuppression using cyclosporine and ORS ATG. And then
Okay.
if after 3 months the patient is not responding, because I understand that she's thrombopenic with possibly hemorrhage complications, then under eculizumab, anticoagulation, platelet transfusions, I would try TPO receptor agonist because definitely she's going to bleed and there will be a problem. So that's what we will manage. We will surely not go for transplantation because of the condition of the patients and also because we know that thrombosis and transplant are doing worse, but we will definitely go for immunosuppression and a complement in.
Okay, sir. And sir, should she be subjected to a splenic embolization? Because the spleen is around, it's almost 10 centimeters.
No, we won't do that because
Okay.
first of all, you will increase the risk of thrombosis. That's
Yes.
the main point.
Yeah. Yes.
And even with a complement inhibitor and anticoagulation, we do know that PNH might reoccur and
Okay.
thrombosis might reoccur. And the second thing is that you will probably create necrosis and you
Yeah.
will probably increase the
Yeah.
risk of hemorrhage
Yes. Yes.
around the spleen. So we will
Mhm.
definitely go for immunosuppression with complement blockers and without using any embolization.
Okay. Sure. Thank you so much.
Thank you, Dr. Akanksha. Agrawal sir, your question.
There is one question in the chat box. You can finish that.
This is question from Dr. Yimon Tent. In a PNH patient, if presenting with high liver enzymes with AST, ALT of more than 100, how would you manage these patients?
So this is very common at time of hemolysis to have liver test dysfunction, and steroids has been not proven because it was not a randomized trial, but in the French registry, steroids are significantly associated with a higher risk of infection. So I would say that I would do a watch and wait. So in other words, if the patients is easy to follow, I would just, I would say, confirm or see if the liver test function are normalizing after the hemolytic crisis. But I would not treat a isolated biological dysfunction. We do know that hemolysis is going on. We do know that liver test dysfunction is quite usual. We know that outside hemolysis, when the things will come back to normal, the liver was normalized. So that's the reason why in that situation, we are not using any treatment.
And also big no to steroids at that time?
Sorry?
Steroids not to be used?
I didn't understand which treatment.
Corticosteroids not to be used?
No, exactly. We are never using steroids in PNH.
Thank you, sir. And one question is from Dr. Kannan. How do you manage aplastic manifestation of PNH?
So that's what I was a bit addressing before. This is the main, I would say, challenge of today. I mean, of the years that are coming. If you have to treat aplastics like the patients would be treated outside PNH. And you have to think about PNH as hemolytic and then treated with complement inhibitors, plastics and treat aplastic anemia. So in other words, if the patient has an indication while being cytopenic of complement inhibition, mainly symptomatic hemolysis, anemias, or transfusions, then you go for complement inhibition, whatever the cytopenic side is. On the other way around, if the patient is presenting cytopenias with indication for treatment, so meaning severe or very severe aplastic anemia, or patients with moderate aplastic anemia being transfused, then you go for treatment and you don't think about PNH. Both treatments can be together. That's not what I'm saying. What I'm saying is that you treat PNH, you treat the plastics, both together, the way you would treat PNH outside the plastics and the plastics outside PNH. Meaning that if the patient is young with a sibling donor, then definitely you go to transplant. And we have some reports using complement inhibitors at the conditioning regimen time, and it's doing very well, and then you are stopping complement inhibitors after transplant. If the patient is not eligible for transplant, and it was exactly the case we were discussing before, then you're going for immunosuppression, complement inhibitors, and immunosuppression same time.
Thank you, sir. And that's what another question from Dr. Kannan has, that is BMT really an option for PNH?
Yes, this is still an option for patients who don't have access to complement inhibitors. We have many countries who are reported to us because our ancestry and historical relationship, like North Africa, Tunisia, Morocco, Algeria. They're reporting to us and presenting patients because we have some multidisciplinary meetings discussing case, and they don't have access to complement inhibitors. So for those patients, if they have a sibling donor, we are going to transplant because the overall survival from transplant patients is far better than the natural history of the disease, especially in countries where you might have a higher sense of having sibling donors. So that's the reason why for countries where they not have access to complement inhibitors, we are still advising transplant because you might cure patients. Of course, they'll still have this 15% mortality, but at least it's not a 50% mortality 15 years.
True, sir. Thank you, sir. Agarwal, sir, your question.
Yes, sir, I have a couple of questions. So if you have a PNH clone of small size, and if you have a subclinical hemolysis, just the LDH high, etc., in long term, do these patients end up with renal damage?
Honestly, it's really depending on hemolysis, right? And what I do observed was patients who are exposed to 3-4 times LDH for a long time because complement inhibitors were not accessible. And then, yes, you have renal damage. But I would say that for a low level of a PNH activity with a low level of hemolysis, the kidneys are staying safe and the kidney function is okay. I would not treat a patient because of this kind of reason, definitely.
Thank you. Now, paroxysmal nocturnal hemoglobinuria, we always used to talk about nocturnal component of it, though things are not always nocturnal, but they are a bit more in the night.
Yeah, so this is very funny because yes, this disease is a paroxysmal nocturnal hemoglobinuria. And in a way, there is nothing paroxystic because now we know that the hemolysis is still going on anytime. And there is no more hemolysing during night. The only thing is that usually at night we are sleeping and the hemoglobinuria is accumulating. And that's the reason why in the morning the urines are more dark. But now we do know that there is no role of acid pH because there was something that will say that there was high rates of hemolysing during nights because you have some modifications in that pH in blood. No, this is false. So we are coming in 2026 to see that paroxysmal nocturnal hemoglobinuria is not paroxysmal and is not nocturnal, but it's still hemoglobinuria.
Right, sir. The next question I have is that there are patients with good hemoglobin, like ITP patients with good platelet count, complain of fatigue. Do we know the mechanism?
Yeah, so this is a very good question. We are initiating at the moment a research on that. At the very beginning, I was thinking, yeah, it's because they are still exposed to breakthrough and they might have some viral infection. And we discussed with our neurological colleagues, and there are still some research coming in and coming out saying and stating that possibly the endocellular activation, especially at the brain level, might cause fatigue. So this is something that we are working on at the moment. We do know that thrombosis is not a problem anymore. Patients are fully protected, and this is not the cause of the fatigue. But we are working with neurological colleagues to identify, and we are trying to find the markers that might be useful of this endocellular activation in the little vessels of the brain that might be responsible for this feeling of fatigue.
Thank you. Some patients complain of erectile dysfunction. Do we know exactly its incidence, etiology, and what to do?
Yeah, so it's clearly because when you have hemoglobinuria that is ongoing, you have a full process to eliminate this hemoglobin that is circulating with hemopexin, haptoglobin, and so on. And at the time, you have a oxidation of the hemoglobin in methemoglobin. We are creating methemoglobinemia because we do know that methemoglobin is less toxic in a way than hemoglobinemia. And this is consuming a lot of nitric oxide. And we do know that in those patients, the level of nitric oxide is very low. And that's probably the cause of erectile dysfunction because we do know that the smooth muscles are very sensitive to nitric oxide. This is also what is explaining what those patients are experiencing abdominal pain, dysphagia, because there is a contractions of the esophagus because of that reason. In terms of treatment, obviously there is complement inhibitors, but when the patients has in a way, I would say just erectile dysfunction, I might understand that that's something that might impair their quality of life, but the treatment are very expensive. So we are treating patients when they are experiencing all the symptoms like anemia and hemolysis and so on, and we are seeing a drastic improvement in terms of erectile dysfunction. However, when they have an isolated or at least some symptoms, including erectile dysfunctions, but not anemias, not hemolysis. First of all, these are rare conditions because usually erectile dysfunction and other nitric oxide depletion related symptoms are in the context of hemolysis, so usually it's very well. And I'm always looking for another reason of erectile dysfunction because usually it's really with the full symptoms of PNH.
Right. Now we have eculizumab available in India. So now those patients who are taking it, besides the vaccination, do they need lifelong some antimicrobial prophylaxis?
That's what we are doing in France. When a patient is vaccinated and using complement inhibitors, honestly, we do not know if he's fully protected since the antibody that are directed against meningococcal infections will be limited in their actions by the complement inhibition ongoing. I'm don't have any publications, so this is more a gut feeling that a scientifically driven answer. But what we do know that those patients are young, so we are given full protection, meaning vaccination and antibiotics. This is what we are doing in France. I know that other countries are not given antibiotic prophylaxis, arguing that we might create resistance. We do know that transplant patients are taking antibiotics for years and they have no resistance, and it's just penicillin. So we are using both vaccination and antibiotics prophylaxis to avoid as much as possible meningococcal infection. Yeah.
Right, sir. Those patients who have had thrombosis and are on anticoagulant, in India, transplantations are the modality of treatment. What to do with anticoagulation after transplants? It should be continued lifelong, or it should be titrated with the PNH clone being present, not present?
So after transplant, we are regularly screening the patients to see how the level or how the thrombosis is doing. So, for example, for Budd-Chiari syndromes, if you have still some hypertension or any reason that you might create thrombosis, we are still giving anticoagulation because transplant per se is associated with higher rates of thrombosis. We have about 20% of patients who are presenting thrombosis outside PNH, and just because of transplant, because you have an endothelial injury using conditioning regimen and so on. So we might stop anticoagulation very long term after transplant, let's say 1 or 2 years, if the patients are at least morphologically speaking with with radiological exams coming to normal. But if there is anything making us thinking that the patients may be at risk of recurring thrombosis, we are given anticoagulation lifelong. So it's really a case-by-case discussion.
And similarly, in the non-transplanted patients of PNH, once anticoagulation has been started, invariably it is lifelong?
So if you have access to complement inhibitors, no. Now we are more and more trying to stop anticoagulation in, again, patients who are well controlled with no consequences of the previous thrombosis. If the patients don't have access, yes, we are obliged to continue lifelong. And we have also patients with very severe thrombosis complications before complement inhibitors were initiated, so that we are continuing lifelong. But again, you're touching down on the clinical research questions that we're initiating in a stop, not stop anticoagulation in those patients. So there are easy cases. I mean, deep vein thrombosis patients are doing great. The ultrasounds are reassuring. We're stopping. And then for more difficult cases, it's really a case-by-case discussion.
Thank you, sir.
Thank you, sir. Does anybody has any other question? Because there are no more questions in the chat box. Well, sir, so in that case, Dr. Divya Manohar.
Hi, sir. Good afternoon. That was a wonderful presentation. I have a doubt, sir. Like patient who is known case of PNH, like an adult female, uh, age of 30 and 27 or 30, planning for pregnancy. So, is there? I mean, the severity is like only the hemolysis part is there for the patient, and patient is right now not on any of the novel therapeutics because of the financial status. Is there any what advice we would give if the patient wants to conceive or to go about for the pregnancy?
So what we are usually doing is giving a complement inhibitors when you have access to complement inhibitors from the 4 months, I mean, at least after the first trimester. We are giving complement inhibitors associated with low weight heparin to protect as much as possible thrombosis occurrence. Then we are increasing eculizumab from 900 to 1200 at the third trimester. It's a very complicated situation because you have PNH complications and aplastic anemia complications. So for PNH, we are giving complement inhibitors and low weight heparin. And for the aplastic side, you'll see your patients worsening accounts with pregnancy. So we are trying to reach a 10-gram hemoglobin level because we do know that, like in sickle cell disease and pregnant women, you may have some consequences in the kids if the hemoglobin level is lower. So we are giving transfusion on red blood cells to reach this 10 gram per deciliter hemoglobin level. For platelets, we are transfusing only at time of delivery. We know that 20 giga per liter is enough for pregnancy, and if there is no problem or any, I would say, reason for bleeding, that would be a problem. So it's really difficult cases, and when you don't have access to complement inhibitors, if the clone size is more than 10%, it might be very risky with very severe thrombosis complications, especially at time of delivery and in the postpartum period of 6 weeks' time. So we are doing this because we have access to it. You will be exposed to both complications, PNH and aplastics. It's very severe conditions. They have to be followed very, very carefully with both gynecologists and hematologists. And yes, now we are even using ravulizumab. We are publishing this, and it's reassuring. But without complement inhibitors, it's a very, very tricky situation.
Thank you, sir. Thank you. So these drugs are safe during pregnancy. Like in third trimester, we can use these drugs.
No worries. Yes, we published this in 2015 in New England Journal. Eculizumab is really safe during pregnancy for both mothers and kids. We had some mandatory reports for kids at time of delivery, at time of the 6 months and 2 years. And in the 50 kids that we reported, those mandatory reports, the development physically and psychologically were exactly the same than healthy babies.
Thank you, sir. Thank you.
Thank you, Dr. Divya. So we have finished all the questions from the chat box. Are you any other question to ask? So there are no more questions in here from the discussions. So thank you so much for the fantastic talk and what a lovely discussion. It is always a knowledge learning session from you because the doubts you cleared regarding the PNH is awesome. Fantastic, sir. Thank you so much, sir.
And again, my deep apologize for having been late. And a good day to everybody.
Thank you. And now hand over to Mr. Prashant for the final word of thanks.
Yeah. Thank you, sir. Thank you very much. It was really lovely and a wonderful presentation with lot of learning. The question has been asked very much profound, and the answers which have been given was wonderful. I hope the medical fraternity will be benefited from this session. And I thankful Dr. MB Agarwal sirs once again to conducting such a wonderful webinar. And thank you, Dr. Amit Khurana, our chief guest and speakers, and all the participants and the discussants. I thanks all of you for participating in this webinar, sir. We, as a company, we are always want to work with you and want to associate with you. Thank you very much for giving us the opportunity. Thanks a lot, and have a good day.
One
So,
request,
everybody.
bring us more PNH drugs through Adley.
Thank you, sir.
Yeah.
You have been
Thank you very much. Thank you. Thank you.
molecules, and we need these molecules.